Restrictive disorders now, we think of these as generally the opposite problem. People with restrictive disorders, their primary problem is getting air in. They don't have so much of a problem getting air out, but getting air in is their major issue. And here, this arrow doesn't do this justice. We point to the primary problem according to Ohm's law for restrictive disorders. And the problem is that pressure gradient has decreased for what should be normal inhalation. Right? And not just the atmospheric pressure. That's, I guess, a bad way of writing it here. It's not that we've decreased the atmospheric pressure. It's the fact that we can't open up the alveolar space enough to drop that pressure to create a large enough gradient to allow for effective airflow in. Right? For resting conditions, the individual wouldn't be able to take in the 500 milliliters for a tidal volume. And so we can effectively, we probably should say this gradient is what is decreased. And given the direct proportional relationship here between that pressure gradient and our total ventilation rate, that means the ventilation rate has decreased. So I noted here that the pressure gradient is decreased due to the inability to expand the lungs to a sufficient volume during inhalation. There's various reasons why the individual might not be able to expand their lungs during inhalation, right? These are two categories of problems that could affect the ability to increase that volume during inhalation. It could be a problem with the stretchability of the lungs themselves, so the material properties of the lungs, or the presence of surfactant within the fluid-filled alveolar space. The presence of that surfactant also gives the lungs stretchability because it decreases surface tension, it decreases cohesiveness within the lungs, within that fluid-filled space. And we'll talk a little bit more about the surfactant because I do want you to know a few important points about the function of the fluid or material that we call surfactant in the lung space. So it could be a problem actually being able to stretch the lungs, right? So the stretchability of the lungs is, and it could be an issue here. Or it could be a problem being able to create that distending pressure, right? Create that transpulmonary pressure, which is what's shown here with the difference between the intra-alveolar pressure and the intra-pleural pressure. Keep in mind that that distending pressure is a pressure differential that tells us just how stretched open the lungs are. The more positive that value, right, the more distended the lungs, the greater that, that stretch during inhalation. So whether it is one or the other, or a combination of two, either of these decrease, the volume will decrease, which means the pressure gradient upon inhalation decreases. That means we have less air coming in, which means in the end, the individual will be exhaling less air as well. We have less overall ventilation, movement of air in and out, and less air to participate in gas exchange in this way. Okay, so here are some basic issues that could occur. You'll see on the previous slides there, and I cut and pasted one of these slides here. This is a flow diagram that shows our compliance factors that affect the stretchability of the lungs here and the distending pressure over here. And so if we go down, we see that issues with the nervous system and being able to allow for ventilation to occur, right? Allow for muscle contraction, for instance, for the diaphragm and intercostals. If that doesn't work properly, right, then we have an issue with the contractile ability of the muscles of ventilation, and we won't be able to create that distending pressure. That's not a problem with the lungs and their stretchability. It's a problem with being able to pull open the lungs upon inhalation. That's a problem with the chest wall or the muscles of ventilation. So that could be an issue. Right? On the other side here, in terms of the stretchability, it could be a problem with the elastic tissue. Do we have enough elastic tissue to allow for the lungs to be stretched, right? Because remember, the elastic tissue allows for the stretchability, but it also allows for the elastic recoil. And then we have surfactant. Surfactant actually accounts for much of the stretchability of the lungs. And the surfactant, as I mentioned, is a material that decreases the cohesiveness of the water molecules within the fluid-filled space of the alveoli. In effect, if we didn't have that surfactant there present in the alveolar space, our alveoli would act like little suction cups. So each alveolus would act like the intrapleural space, the pleural cavity, and we get this suctioning effect. And once they're closed, they would be very hard to open again due to that suction, that negative pressure. And so the presence of this surfactant with specific material properties breaks up that cohesiveness of the water molecules, separates out the water molecules so they can't easily form hydrogen bonds with one another. We say that it interrupts the surface tension that would be created within the alveolar space. And in this way, the surfactant allows for the alveoli to more easily expand upon inhalation. That gives the lungs lots of stretchability in this way. And so it's very important for lung compliance, the stretchability during inhalation that occurs. So we'll take a look at a few of these different problems. And we're going to focus on one in particular, which would be pulmonary fibrosis. In pulmonary fibrosis, the main problem here would be a problem with the loss of elastic tissue and replacement of that elastic tissue. So it's a different issue than what we see here with emphysema, where we just have loss of elastic tissue and not replacement of that tissue with less elastic tissue. So let's go to this here down at the bottom. We talked about the compensation and the problem here, and this actually doesn't show the compensation, the C for compensation, there we go, that is occurring for the individual with restrictive disorder. Their issue, their constraint, if you will, is that their tidal volume upon inhalation is reduced. When they breathe in, they can't expand the lungs appropriately, and so they're going to be forced to have shallow breaths. And if that's true, if their tidal volume is down, in order to maintain or try to maintain a normal total ventilation rate, match their ventilation to perfusion, they can increase their breathing rate. And so we typically see that individuals with restrictive disorders have shallow breathing, and they also breathe quickly, fast, shallow breathing. This is a pattern associated with restrictive disorders. All right. So I have two slides here that have restrictive disorders. And in some cases, I have notes not so much about the breathing pattern, because we expect to see the same general breathing pattern, a quick rate of breathing and shallow breathing for individuals with these restrictive disorders. But I do have some notes about treatments when they're useful. And the first one I want to point out here is emphysema is on this list. I have it here in red because we're going to consider it to be primarily an obstructive disorder. So if I ask you, to list here, what are the obstructive disorders, it would be asthma, chronic bronchitis, and emphysema. Emphysema could technically be a restrictive disorder because one of the definitions of a restrictive disorder is the decreased production of surfactant, right? If we have decreased surfactant, we have decreased stretchability of the lungs is the idea. And individuals that have emphysema typically have destruction of not only the alveolar cells themselves, but the type 2 cells in the alveoli that produce the surfactant. And so it's possible that they have damage, death of those cells. They'll have decreased surfactant production. They might have a tendency for alveolar collapse, right? That could be the case, but their major issue is that they have overcompliant lungs due to that lack of elastic tissue, right? And lack of elastic recoil upon exhalation. Their lungs are too stretchable, and generally they have no problem expanding the lungs upon inhalation. Taking air in is not an issue for the individual for emphysema. It's getting the air out. So by technical definition, an individual with emphysema might be put into this category of restrictive as well if they produce less surfactant. But we don't see that actually play out in terms of their breathing pattern, their actual problem as being a restrictive disorder. It's an obstructive disorder for them. It's getting air out, not in. Right? So I just want you to be aware of that. And that's one of the tricky things about emphysema. Right? I mentioned this to you, and I don't want the thing that sticks in your mind is that you saw it here as a restrictive disorder. It is an obstructive disorder. And I'm going to make sure I beat this into your brain right now. The problem is overcompliance, not that the lungs are not compliant enough. Lots of people mix those two up for emphysema. The lungs are too stretchable. So stretchable, they can't recoil. So think about your favorite t-shirt, your favorite pair of socks. You wear that t-shirt for a long period of time, those socks too long, and you begin to lose the material properties, right? You stretch that t-shirt out, it becomes very stretchable. It doesn't recoil back to its original form after a while. Same with those socks that you love, right? And that's what happens to the lungs for an individual with emphysema due to that loss of the elastic tissue. And they don't replace that elastic tissue, right? You kind of think of their lungs as becoming Swiss cheese over time. They're losing tissue and they're not replacing that tissue. Compare that to the individual who has pulmonary fibrosis. Pulmonary fibrosis is a restrictive disorder. Here, the individual with pulmonary fibrosis, they have lost elastic tissue in their lungs, but they've replaced that tissue. They've attempted to repair their lung tissue, but they're replacing the tissue with collagen deposits. And collagen is not the same thing as elastic tissue, is not stretchable. So they have now a decrease in compliance, a decrease in the stretchability during inhalation. Why would that occur for them? Well, the loss of elastic tissue may occur due to a variety of disorders. It could be an autoimmune disorder, could be an inflammatory disorder that causes this tissue destruction, and then provokes this attempt at repair. Certain types of drugs and toxins can have this effect. Airborne pollutants, once again, could also lead to destruction of that tissue. And then depending on how the body responds, we either get the body attempting to repair itself and not doing so properly, or not repairing itself, and then we just have overcompliant lungs. That's emphysema. So here, the individual with pulmonary fibrosis, they're going to have trouble expanding their lungs due to the replacement of that elastic tissue with less stretchable material. There are not many treatments for pulmonary fibrosis, but there are some new medications that are just coming on the market more recently. And these are medications that actually downregulate collagen production. So if caught early enough, downregulating collagen production can decrease, some of the repair that happens here that would decrease the compliance and stretchability. Doesn't mean that it stops the tissue destruction in the first place. That's another issue. that would need treatment for the individual with pulmonary fibrosis. The other issues that I have here, ones that we would consider here as being problems with the chest wall or the muscles of ventilation. So on this side, in terms of being able to create that distending pressure, right, and pull open the lungs. For instance, a pneumothorax, if that occurs, hemothorax, what have you, gunshot wound, stabbing wound, anything that disrupts that that pleural seal between the chest wall and the outer lining of the lungs, means that we have lost that suction. We say that the intrapleural pressure is now less negative, and that's going to decrease the distending pressure if that pressure becomes less negative, if it becomes positive, for instance, with the air and blood that could enter that space and disrupt that seal. Right. Chest wall issues, anything that could be structural in nature or have to do with the ability of the muscles to contract. Myasthenia gravis is a good example here, the autoimmune disorder that causes destruction and blockage of knackers on skeletal muscle. Okay, so that would affect the diaphragm, the intercostal muscles. And we know that individual with myasthenia gravis, if they have myasthenic crisis, they have problems with respiration. That could lead to respiratory failure because they're unable to ventilate properly. In this case, it becomes a restrictive disorder. They can't get air in because they can't move the muscles to allow for expansion upon inhalation. And other types of problems with the chest wall, deformities, kyphosis, which refers to a humpback, scoliosis, spinal curvature, what have you, and fall into those categories. And then we have surfactant issues. I don't need you to know the specific surfactant issues here. Much of this has to do with the ability of the surfactant producing cells, the type 2 cells in the alveoli, to function appropriately. Cystic fibrosis is a genetic disorder that disrupts the ability of these type 2 cells to produce surfactant, so we get less surfactant production. Adult respiratory distress disorder, some type of damage or pollutant, even positive pressure breathing, so breathing on a ventilator over a long period of time, can cause damage to those type 2 cells. And now they can't make enough surfactant. This could happen before birth, especially with premature births, given that surfactant production typically doesn't begin until 26 to 28 weeks into gestation. So if a baby is born prematurely, it might have very low, if any, surfactant production. And that's going to cause large problems with stretchability during inhalation for the newborn. And that's called infant respiratory distress syndrome. So what I wanted you to know about surfactant and surfactant issues, we'll just take a few notes here regarding these disorders. First off, think about what surfactant is, how we would define surfactant. These are amphipathic molecules. That means they're, whoops, supposed to be a D, not really. Hydrophilic on one end and hydrophobic on the other end. And they're produced by those cells called type 2 cells. In the alveoli, okay? And I'll show you a picture of that in just a moment. But the other notes I wanted to make here before we look at a few diagrams together, before we end this review. the function of a surfactant is to decrease alveolar surface tension. They decrease cohesiveness of H2O in the alveoli. And what that will then lead to, what that will produce, is an increase in alveolar compliance, stretchability of the alveoli. The more we can stretch open the respiratory surface during inhalation, while we're bringing air in for gas exchange, the greater the surface area for gas exchange. We'll create greater surface area by stretching open the alveoli. So when we have a great increase in alveolar compliance, we get an increase in surface area for gas exchange. So we get a way to maximize that gas exchange with the presence of surfactant. All right, any questions about those points before I move away from this slide and we just take a look at a few diagrams? Our surfactant, like this diagram, gives us a picture of the alveoli. And here's our fluid-filled space. We have a fluid film within the alveoli so that we have a fluid in which to dissolve gases so that they can first dissolve in fluid before they enter or enter cells and enter blood plasma, for instance. That would happen with oxygen and with CO2. We'd see that the CO2 would enter the cells from the plasma and then exit through that fluid film. But that fluid film is aqueous film, so it's mainly water. And the great thing about water is its cohesiveness, and the bad thing about water is its cohesiveness, especially here within the alveolar space. As I said, we want that cohesiveness in the pleural cavity. We want to have that suction to allow for the lungs and the chest wall to move together during the act of ventilation, but we don't want that same suction within the respiratory spaces. The spaces that are supposed to open up to allow for gas exchange to occur. So we have these type 2 cells that produce the surfactant, and the surfactant itself, being an amphipathic molecule with its hydrophilic side and hydrophobic side, is able to intersperse itself at the surface. So here we are at the surface, right? And interact with the water molecules with the hydrophobic region. The hydrophilic region is facing out at the fluid air boundary here. And that breaks up the surface tension. And what that means is it's blocking the ability of the water molecules to form hydrogen bonds with one another. And so when we have fewer hydrogen bonds forming, we have less cohesiveness at that for that fluid film. And if it's helpful, you can think of surfactant as a detergent in this way with the hydrophilic and the hydrophobic side. A couple of notes about the surfactant's ability to allow for this decrease in surface tension and then increase the alveolar compliance is we often have to take into account the size of the alveoli. They do differ in size. Some are larger, some are smaller. And the same rules for Boyle's law apply to individual alveoli. You compare this alveolus and this alveolus here, A and B, this here is a larger space. It has a lower alveolar pressure than the small alveolus. It's going to have a higher alveolar pressure, right? Given those size differences. And so when air flows in, air is always going to be biased in this direction, right? Away from the small alveoli. And those are generally the ones that need the greater air pressure in order to help them stay open. Because they're smaller, right? The water molecules would have greater interactions, create greater surface tension. They're more likely to collapse, the small alveoli. So we would want to see that air moves in that direction towards the smaller alveoli more so than the larger one. We want to see that any type of situation that favors that, and surfactant allows that to happen. And what I'm describing here is what's called Laplace's law. I want to point this out for you, not because I'm going to ask you about Laplace's law on this exam, but I will ask you about Laplace's law actually on the final exam. We asked you about all the laws on the final exam. So just want you to be aware of that now. It's going to be a little bit of a matching scenario here. Do you know the description of these given laws that we've discussed throughout the semester? Some of them should be easy at this point, like Ohm's law and Poissier's law, right? Even Boyle's law. But we'll bring in like Dalton's law as well. We'll talk about Henry's law next time for the final in terms of our external-internal gas exchange. Laplace's law is one that will be there as well. So I want to run through this law with you. What Laplace's law tells us, and we're going to start with a scenario where there's no surfactant present, right? So we're taking surfactant out of the equation here. It would tell us here that our distending pressures, this is what we can think of as the distending pressure, the pressure needed to keep an alveolus open, think of it this way, right, is directly proportional to the surface tension. So this is our surface tension. So what this means is if we increase the surface tension, we increase the cohesiveness of those water molecules, we need a greater pressure in order to keep that alveolus open. That makes sense, right? Here, there's an inverse relationship between the distending pressure and the radius of the alveoli. So this is radius of the alveolus. That inverse relationship tells us if we have a decrease in radius, a smaller alveolus, we need a greater distending pressure to keep that small alveolus open. Because of that bias, once again, that air flows down pressure gradients, and the larger alveoli always have the lower pressure. Air is going to be biased and moving in that direction. So we need a large distending pressure to keep those small alveoli open as well. A large pushing pressure, if you will, upon inhalation. Okay, so now let's think of what surfactant would add to this equation. So this right now is surfactant free. That would be the basic relationships we would see. Small alveoli have high surface tension, right, and need a large descending pressure in order to keep them open. With the presence of surfactant, we see for a small alveolus, when we add surfactant, we actually decrease the surface tension greatly. You get this magnifying effect, and I'm going to show you why we get a magnifying effect in just a minute. So we do this when we add surfactant. We'll add surfactant. Now those molecules break up the cohesiveness of the water molecules within that aqueous film. We've decreased the surface tension a lot. What's that going to do to the distending pressure necessary to keep the small alveoli open? That's going to decrease the amount of distending pressure we need. And in this way, it makes it equally likely that as air moves now into the air passageways into the alveoli, equally likely that the air will move in the direction of the small alveoli and the large alveoli. And in part, that's because we get changes in the activity of the surfactant as the alveoli expand and as they shrink, as they change volume, which is interesting to think about. The surfactant itself, we don't change the amount, but since we're changing the size of the alveoli, as we expand the lungs and as we recoil and decrease the volume of these alveoli, we're changing the concentration of that surfactant, right? Bigger space, less concentrated, smaller space, more concentrated. More concentrated, we get a greater effect of the surfactant. And for the small alveoli, they're already small, so the surfactant will always be more concentrated in those small alveoli. And when they undergo recoil and we decrease that volume, the surfactant gets even more concentrated and has even greater effect at decreasing surface tension. So that's why we see this relationship where surface tension decreases by a lot by having surfactant present. The ability of surfactant to have an effect that changes as the alveoli actually change in size during the process of inhalation exhalation, which is pretty interesting to think about. And so that information is here. There's some slides that show that dynamic with and without surfactant, right? And it's also mentioned here. Alveoli undergo through cycles of inflation and deflation. Surface area increases, decreases. Surfactant becomes more or less concentrated. Right? It becomes easier to inflate the alveoli, especially the smallest of alveoli. Right? They have a decreased tendency to collapse with the presence of surfactant. All right, so those were the points I wanted to make about surfactant and to mention Laplace's law.